Thanks everyone for being here. This is the ATS Critical Care Assembly Early Career Professionals Working Group Spring Virtual Grand Rounds. We are so fortunate to have two phenomenal researchers who I'm going to introduce in a little bit. We've titled this session Decisions, Systems, and Survivors: What Qualitative Research Can Teach Us About Critical Care. And so the early career professionals who we're highlighting today are just that. They're doing qualitative research and really discovering, I think, another layer of within critical care research that's really valuable. So we're in for a treat. Brigitta Fazzini is an advanced critical care practitioner in the adult critical care unit at the Royal London Hospital and also a PhD candidate at the Queen Mary University of London. She conducts her research as part of the Critical Care and Perioperative Medicine Research Group, of which she's been a member since 2020. And she uses qualitative and mixed methods techniques to investigate patient and clinician experiences and perspectives related to things like acute respiratory failure, non-invasive respiratory support, muscle dysfunction and critical illness, and acquired functional disability. So we're very, very fortunate to have an international perspective for today's Grand Rounds. Katie Hauschildt is an assistant professor of medicine at Oregon Health and Sciences University. She completed her PhD in sociology at the University of Michigan and a fellowship in health services research at the Center for Clinical Management Research at the Veterans Affairs Ann Arbor Health Systems. Her research focuses on identifying structural and organizational factors which influence equitable critical care delivery and developing interventions to improve critical care transitions and recovery following critical illness. I'm going to hand the floor over to Brigitta to get us started.
Thank you, Kelsey. Thank you so much for inviting me here. So I'm just going to share my slides, which I hope you may be able to see shortly. Great, I can see a thumbs up, so that's fantastic. I'm so excited to be here and to really share some of what is actually the theme of my PhD. So I'm really interested about acute respiratory failure and how do we use some advanced type of monitoring really to tailor what we do with high flow, with CPAP and BiPAP. So really, my slides are going to tell you some of the work that I have been doing. You all know really that acute respiratory failure is really heterogeneous. We use a lot of treatment, and some of those are the first line that we use are high flow, CPAP and BiPAP that we use with few type of interfaces like face mask or really helmet. And patients don't really just stay on high flow. They go from one to another really in a very various flow. So they may go from CPAP to BiPAP and then have got a break on high flow. And how do we use this treatment is really based on some type of basic monitoring that we use, like clinical assessment, respiratory rate or ABGs that we do. And the way of how we assess patient is really subjective. How do we assess them is really then changing from one to another. And then the decisions that we do are really variable. And we know from the UK, from the NCPOD report that what we do and how we decide on the treatment really affect outcome. So the aim really of the work that I'm trying to do is really try to understand of how we can personalize care and whether actually acute respiratory monitoring can really help us in doing that. And really trying to see how we can integrate in what we're currently doing. So the first step that I did is actually try to evaluate what type of monitoring we had out there. So if you're interested in that, you can scan the QR code and you can see the review that we have done. You probably know this already. There are some type of monitoring that we use for patients on high flow and CPAP and BiPAP, which goes from those who are more invasive to those that are less kind of invasive. The gold standard is esophageal manometry, so you can detect esophageal pressure with it. And you can definitely have the gold standard for inspiratory effort. Then we've got NAVA that is mainly used in the lab or for the research that we do, but it's the gold standard for drive. And then some of us use EMG, ultrasound, and ERT. But as you can see, all of those kind of monitoring don't tell the same things. And some of those are really not the gold standards, but perhaps we use that in real in the real ICU. What can they tell us and what can they do for us? They can perhaps tailor the support and the treatment that we use, so they can perhaps help us to titrate flow or PEEP, or they can perhaps help us to know when it's time to escalate the treatment that we use, when it's time to intubate, and so perhaps see when the patient is failing. They can potentially help us to reduce the variability in care that we have, and can hopefully help us in try to communicate in the same way. So perhaps brings the physio online with what we are trying to do. So really have a sharing way to work. But before we actually do that, we need really to understand if actually how do we use that? So how do we use the quantitative info that we have from the monitoring that we use? And this is a work that we have done, is really try to understand how we decide on the treatment that we use every day in the ICU. And we try to actually show this in this nice infographic that we have here. And actually we saw that how we decide on the treatment is actually really complex. So there is some intrinsic and modifiable factor that we take into account every day as a staff, really. And these involve the patient that we have and that we try to treat. So every patient is not the same, and the disease that everyone have is not the same. And this is really true for ARF, really, as it's quite heterogeneous, and not every patient can really tolerate the same type of treatment either. Then we do have us as staff, and we do have our belief, the confidence that we have. We perhaps follow the guidelines or we don't. So that is really variable as well. And then the treatment that we can do in the ICU is not the same as we can do perhaps on the ward. So really the environment that we are inside really can affect the way of how we decide as well. And the team that we are involved as well will affect that also. So the way of how we decide is not just based on the quantifiable info, but also whether what we have can be used, and that can then affect the actions that then we actually do. So we really try to break this down and really try to see what type of monitoring we have and what they actually do, and show you that in 2 slides ahead, really what type of monitoring we have. And then we try to dig down in really how clinical staff and patient accept those, or how can interpret those type of monitoring, and then see how can be used, and then whether this can actually change care that we provide every day. And so we really wanted to shift the evidence and the perspective, not just in the monitoring and the tool that we have, because as I always say, there is no point to have a fast car if the team around us cannot really work together. And if anyone who actually watch the races, it's not just about whether the car is fast, but it's whether the drive can stay really focused, whether the team really works. So it's not just about the tool that we have, but it's whether this can actually use in real life. So what we did, we actually wanted to see the technical performance of this monitoring. We wanted to investigate the usability and acceptability, so whether this actually can be tolerable and applicable and feasible in real world, and whether this actually changed the way of how we decide in the treatment. That can then help us to actually see whether we can then implement those in the real ICU life. So this is really just to show you that if we don't have the acceptability and the usability component, we can have a perfect tool like esophageal that is the gold standard, but we don't apply it. So really understand the gaps that goes from the technicality to actually the effectiveness can really then allow us to use the tool and potentially change outcome. In the UK, we actually have got an acceptability framework that we use that is actually being done by the NIHR and is a framework that tends to define what acceptability means. And this is actually quite interesting because you may think that acceptability is just for patient because are the one who then are gonna have the intervention. So in this case, the intervention are actually the monitoring tools, but they also arrive in the treatment, and that the treatment is high flow or CPAP and BiPAP. So you can already see how this can be tricky and complex. But it's not just their perspective, it's also the staff perspective, because they are the one who are going to actually deliver that and use that, but also doing something with the info that they're gonna come from the monitoring itself. So there are two ways of the story, really. And this acceptability framework is actually quite interesting because it's really trying to deconstruct what are the components that may affect that. And it's actually made of 6 domains that really dig down into what can be the challenges, the ethical consequences, the experiences, but also the attitude of staff who then actually have to interface with the monitoring and the treatment. They actually tend that want to actually titrate.